Right, good morning or evening to all of you who have tuned in. My name is Nataly Martini. I am going to be talking with you about virtual patients versus mannequins in interprofessional learning in healthcare. Right, so are you ready to practice? So in the scenario you're faced with a life-threatening emergency, in real life your patient would not deteriorate so quickly. But for the purposes of this game or simulation, you will need to avoid wasting time. So are you ready? Let's see. So here you are with a patient in a hospital. The nurse is providing you with a medical handover and she's giving you some information. You're probably not hearing all the sounds in the background via Zoom, but you've got beeps and all of these sounds of the hospital, people chattering in the background. All right, so what do you want to do? You can either read a GP letter, check the cardiac monitor, check the computer, or talk to the patient. So I'm going to stop that for a minute and pause. And you can decide what you would do. Now, if you're a trained healthcare professional, you most likely have an established clinical decision-making process that you use to work through clinical problems. Although there's no one correct method, clinical decision-making involves a number of different processes to determine the probabilities of what's going on. And these can use patient symptoms or history, and then gathering information and looking at vital signs, possibly a physical exam if that is an option, and then updating the probabilities based on the data that's gathered in order to consider an intervention. Now, for students who have very little in the way of experience, clinical decision-making processes are quite slow and deliberate, and that's important for them to be able to establish the medical diagnosis and treatment plan. So for medical students who've gone into the simulation, they might opt to speak to a patient first to gather the medical history, while pharmacy students, for example, might check the drug chart first. But whatever approach is taken, the goal really is to recall knowledge that the individual student has learned through their course and apply it to the case. So with our fast-changing healthcare environment, we actually presented with a significant challenge, and that is to produce work-ready graduates. So while students are rapidly keeping up to date with their notes and evolving medical science, they also expected to become these really great self-learners who demonstrate clinical competence, they can practice sound clinical decision-making skills, and be effective communicators, not only within their own discipline, but also in interprofessionally. And so to meet these requirements, students need to practice. So they need to practice applying their knowledge and their skills in a variety of patient cases and medical conditions, both uniprofessionally or interprofessionally. But often, the clinical reasoning and opportunities and how to work within a clinical environment in an interprofessional way is not explicitly addressed in the undergraduate curricula. And also our traditional teaching methods with clinical placements don't adequately address this need. Oftentimes there's a lack of adequate placement sites, there's poor student engagement in these activities, and there's also safety concerns with using real patients. So to solve these problems, the use of simulation has been used to mimic or imitate real patients and clinical cases. Using high fidelity simulations, as you can see in this picture with medical mannequins, has proved to be very effective in engaging students. They can help students develop a wide range of technical skills where they can intubate the mannequin, they can do all of the tests that they need to do, And it also helps them with non-technical skills, such as communication within the team, leadership, and also insight into other people's roles who are involved in the care of that patient. However, it comes with quite a few challenges, and medical mannequins are extremely high cost, and it's incredibly logistically challenging in order to get all of these different disciplines to work together at specific times of the year. Now, at Auckland University, interprofessional learning using mannequins only occurs once in the whole undergraduate curricula of nursing, pharmacy, medical students, and paramedics as well. So the amount of resources that go into organizing these days is enormous. And so ultimately, it only is able to happen once during that time. Virtual patients are also incredibly powerful teaching technologies, and they simulate real-life clinical scenarios, probably to some extent as the mannequin simulations do. But there's a number of distinct advantages of virtual patients over mannequins, and these I'll talk about with you in a minute. So virtual patients are essentially any type of computer program which uses a patient which the student can then interact and engage with. There are physical limitations, of course, to it, but the students can engage and interact through conversations. So like mannequins, they are incredibly effective in teaching certain things like clinical skills and teamwork and communication. And also, they provide a safe space where the students can practice without having any negative consequences on real patients. But the distinct advantages of virtual patients is that it doesn't necessarily require co-location of students or even alteration of existing timetables, since this type of engagement could occur in the student's free time. Furthermore, they're actually a really great supplement to enhance mannequin-based simulation and can better prepare students for the mannequin-based interprofessional learning opportunities. So although the initial costs of virtual patients can be quite high and it can be quite time-consuming to develop, once they're developed, they are essentially free to offer as part of that curriculum, and they can be scaled fairly inexpensively to larger cohorts of students, which can then be available anywhere at any time from a range of different devices. So the Ready to Practice simulation, which is what you saw at the start of this presentation, was born out of a need for pharmacy students at the University of Auckland to have more clinical placement opportunities. And the simulation was intended to be relevant for both medical and pharmacy students. And so the case, which was designed by a multidisciplinary team, incorporated elements of diagnosis as well as medication management. We chose to use an acute renal failure scenario caused by drug interactions so that it could be used to meet the learning needs of both medical as well as pharmacy students. And in New Zealand, as there are in many other parts of the world, the Indigenous people have faced enormous health disparities. And so as a result, we decided to make our virtual patient a Samoan man with type 2 diabetes to allow for the opportunity to address the disparities that occur with Maori and Pacific Island populations. So this then gave the students an opportunity to look at bias as well as clinical reasoning in healthcare. So when we looked at the virtual patient simulation with pharmacy students alone, there were some challenges. And one of the biggest things that students did say about working on the simulation was they had a sense of being alone. So they didn't have anyone to call on. And so they weren't really sure how to address certain challenges or certain problems within the virtual patient simulation, such as ECGs. And so we designed a small study that looked at interprofessional opportunities using the virtual patient, So we had 40 students. We split them into two groups. We had 20 pharmacy students, of which 10 worked in a team with medical students and 10 worked alone, and then 10 medical students who worked alone on the simulation as well. And so what we found using a readiness for interprofessional learning scale is that all students, there were significant differences in their attitudes towards interprofessional learning, but it occurred more so with the medical students than the pharmacy students. And they tended to show the greatest improvement towards teamwork and collaboration, whereas all students saw a positive attitude towards professional identity. And so with the interviews, there were quite a few themes that came out of that. And the simulation enabled students to communicate their ideas, to clarify their own role in patient care. It helped them to gain insight into others' knowledge and skills, and they saw collaboration as an opportunity to share decision-making and responsibility. Some teams, however, found that communicating their thought processes was quite challenging, and that was largely due to barriers of knowledge and confidence. So while pharmacy students had a good knowledge of the scenario, they often didn't have the confidence to voice their opinion. And this happens with medical mannequins as well, where students working together often perceive other disciplines as knowing more, and that prevents them from actually talking about what they see and what their thoughts were. And so that obviously had an impact on the patient outcome. The students took a lot longer to make decisions, and so they needed to restart the simulation again, because within the simulation, the patient can actually die if you don't make those decisions fast enough. Most of the paired medical students admitted that they wouldn't have the confidence to complete the scenario on their own, and that working together with a teammate aided their decision-making processes, but also when the pharmacy students vocalized their opinions, it really helped them to link aspects that they had learned in class. So it was evident that students did have different levels of knowledge, and so they handled the diagnostic and treatment decisions differently. In some cases, the students spent quite a lot of time justifying their opinions or decisions to one another, which increased the time to make that diagnosis. And so what we saw with the virtual patient simulation is what we often see with the medical mannequins as well. Now, Ready to Practice was never designed to be used as an interprofessional learning simulation. It was always designed for single users. And so for students to work together, they needed to physically be together. And that posed certain challenges, because one student could operate the computer, which often led to the other student being quite frustrated because they couldn't do their own thing. The second point was really selecting students with the same level of knowledge. So third-year medical students and fourth-year pharmacy students were selected because they were both preclinical, and so we assumed that they were at the same level. But pharmacy students had a really good baseline knowledge of this particular condition. They had covered it and they knew the drugs, whereas the medical students hadn't covered pharmacology in great detail, and so they really struggled with that. And so for the pharmacy students, they felt that they would have actually done the simulation better if they did it on their own, or at least faster. So integrating virtual patients often requires really careful consideration and planning. If it gets introduced too early, where the learners have not really grasped that core knowledge, it can cause cognitive overload. And for those students, perhaps other methods like role-playing patients might be more effective. However, the opportunities for using virtual patients may include a number of different approaches. So a blended learning approach where there's synchronous and asynchronous learning, and students could engage using different technologies. So having a student, a medical student, for example, using the simulation on a computer and then paging or sending an email or text message to a pharmacy student around certain aspects of the simulation, for example, the drug chart, would allow students to use those technologies a little bit more wisely. And also they could perhaps do that simulation over a period of a whole day or perhaps a week, or even connect at different time points of the year. So there are great opportunities for using virtual patients that are not easily accessible in other forms. And furthermore, a number of different cases could be developed that could include a diverse range of patients with different ethnicities, genders, psychological, behavioral makeup, and that could also provide educational opportunities around challenging healthcare bias. So although it's recognized that virtual patients will never replace real patients entirely, it's really imperative that for that learning to occur, the aspects of the technology shouldn't distract from the realness or the experience of the simulation. And so for that to occur, a number of design elements need to be considered. So with Ready to Practice, we found that the visual aspect really closely needed to match what the patient was saying or doing. If the patient was experiencing pain, but was smiling in a photograph, it created a disconnect for students. Sound, you didn't hear the sound. I'm assuming you didn't hear the sound in the first few slides when I took you through the simulation, but that was really important as well, because it enhanced the immersion in the simulation. So it mimicked a real hospital environment. And for a lot of the students who had not been in a hospital environment, but had seen hospitals on TV shows and in movies, that kind of really created that connect. Whereas for the students who had been in a hospital environment, they really recognized that. And so the environment also reinforced the realness for the students. The conversation system needs to be simple, and students need to be able to have an ability to communicate with the patient. Ideally, it would be using natural language, and this is becoming a lot more available and accessible with natural language processing. However, it's also important to bear in mind that that does add to the cost of development and the time of development. And so more research really needs to be done to consider whether those types of conversation tools actually add that value to the simulation. One of the most important design aspects or important aspects of a well-designed simulation is the relevance. If the students don't see relevance, they will get frustrated and they won't do it. So when doing the simulation on their own, a lot of the pharmacy students did voice that frustration. They felt that the simulation was not designed for them. Even though there was a drug chart, they focused on the things that they couldn't do, such as read an ECG. So really importantly, it does need to be relevant, and it needs to mimic what the students understand under the healthcare approach and what they've learned in class. So with healthcare, we've moved towards a patient-centered model of care. Simulations need to take that into account and need to allow students to transfer that knowledge into deliberately practicing those clinical skills. As with other learning approaches, challenge is to create a simulation that will help the weaker students develop their skills while still engaging and developing the stronger students. Feedback, always critical. Finding a way of incorporating that into the simulation is really important. With a blended learning approach, you could have that within the simulation or have a debriefing session after the simulation within a different type of setting. Building opportunities for assessment in a way that doesn't break the flow of the simulation, whether it needs to occur seamlessly within the simulation. And so you want to actually be able to assess whether learning is occurring, and also collecting data to be able to give you information about that student performance and to identify areas that require attention. So that's really critical in order to be able to see what is going on the back end. So with that, thank you very much. If you've made it to the end, I appreciate your attention. We are aiming to continue to develop our simulation, welcome any collaboration as well as any feedback that you may have. You can read a little bit more about our simulation in the paper that I've attached for you there, Otherwise, please don't hesitate to get in touch with me if you have anything that you would like to share. So thank you very much. I appreciate it.